I'm a clinician. I do lots of research, so unfortunately many people consider me more of a researcher, but that just sort of developed serendipitously. I straddle two worlds, so I'm a professor of anesthesiology and physical medicine at Johns Hopkins, and I run their Blaustein Pain Treatment Center, and so it's an inner city academic hospital. And then I'm also a professor at the Uniformed Services University of the Health Sciences, which is the military medical school. I direct pain research at Walter Reed. So my interests are spinal pain, so back pain, neck pain, neuropathic pain, and I have another interest in war-related injuries or traumatic injuries that result in pain. I think one of the biggest things, I guess a year ago I was the chair of another conference called ASRA, American Society of Regional Anesthesia and Pain Medicine. So it's a little bit different. I had to put the program together, and so I got all the evaluations. And one of the biggest things that people are interested in, and a lot of journals have special sections on this now, are debates. So the three debates that I'm going to be involved in are areas that relate to my research interests. So epidural steroid injections, usually for sciatica or back pain shooting into the leg, and facet joint pain, which is usually axial or mechanical back pain, mostly due to arthritis. And in one of the debates, so do you need an MRI before a lumbar epidural steroid injection? So we had published a clinical trial on this in, it's now JAMA Internal Medicine, so it was Archives of Internal Medicine because it was a couple of years ago. And we found that you didn't need an MRI before getting an epidural steroid injection in the low back. And I did, with the same person that I'm debating tomorrow, with Tim Mouse, we did a point-counterpoint discussion for a journal. One of the biggest barriers is that pain medicine is a fragmented specialty. So compared to, let's say, cardiology, where you just came back from, right? You have all of the people who are cardiologists, I guess with the exception of maybe pediatric cardiologists, they're all internal medicine doctors. So they'll have the same training. And there are different kinds of cardiologists. But that's not the case for pain medicine. So right now you can have primary board certification in 4 specialties, and it will soon be 5. So anesthesiology, physical medicine and rehabilitation, neurology, psychiatry, and soon to be radiology. But there are many other people who do pain medicine fellowships. So my principal investigator at the DC VA hospital is actually an internist and a PhD. And a good friend at Beth Israel Deaconess Hospital is an emergency room physician. And you have psychologists as well. So pain is a huge area in psychologists, and it's a very, very large component of neuroscience. Pain is the, I guess, second most common reason that people visit doctors. So if you look at the largest society for pain, the largest clinical society, that would be the International Association for the Study of Pain. So I'm also on their planning committee for 2016. But the reason I'm on their scientific planning committee is because they don't have a lot of people who do interventions. So there's usually between 5 and over 8,000 clinicians who attend this meeting. Most of them are neuroscientists, psychologists, you have neurologists. So there are over a dozen different organizations that deal with pain. And they all have different perspectives. There are some organizations that are very vocally and I would say blatantly anti-procedure. There are other organizations that are anti-opioid, and so we don't really speak with a unified voice. So that's one barrier. There are other barriers. So even when we show that things work well, there might be, by the time that something is proven to be effective, there may be a 5 or a 10-year lag before it's widely clinically implemented.